Welcome everyone. This is the first of the Milner autumn seminars, so great you could join us. And it's a real pleasure today to welcome Adrian Liston, Senior Group Leader at the Babraham Institute. Adrian's lab focuses on the interface between regulatory T cells and tissues, looking at how to develop new tools for uncovering novel biology. And prior to joining the Babraham in 2019, his research took him across the globe, we understand, from the Australian National University over to the US at the University of Washington, and I think most recently the University of Leuven in Belgium. And in addition to his lab at the Babraham, he was made a research fellow at Churchill College last year. And this year he was elected as a fellow of the Academy of Medical Sciences. And we were particularly excited to see that he finds time beyond the lab to also write and publish children's science books, including all about coronavirus and Battle Robots of the Blood. So we'll definitely be checking those out. But today his talk will be entitled Treating Neuroinflammation Through Targeted Treg Expansion. So many thanks, Adrian, and I'll hand over to you now.
Thank you very much. It's a pleasure to be here and to start off the seminar series. Can I check that my screen is visible?
Yep, all good.
Okay, wonderful. So as mentioned, I want to talk about treating neuroinflammation and in particular through targeted Treg expansion, but how we can use this principle for the development of novel drugs to treat neuroinflammation, neuroinflammatory diseases, even neurodegenerative diseases. Okay, so traumatic brain injury is one of the major focuses of our lab, and it really is a major global health crisis. Every year, there are 50 million traumatic brain injuries around the globe, and these vary a lot in terms of severity. So on the left, there's a picture that a lot of people will be familiar with. That's Muhammad Ali. He had multiple different events of a mild to severe concussion, and he ended up having an early form of neuroinflammatory cognitive decline. It is becoming obvious that this is more and more common in high performance athletes and also victims of domestic violence. You also have people like my brother on the right. This is Russell Liston. He was a paramedic who had an accident 11 years ago, and he had a traumatic brain injury that he was left completely brain dead from and never was able to recover. So we have every year 25 million people that are left with cognitive impairment after these traumatic brain injuries. As a reference point, more people are left with cognitive impairment after a TBI every year than the numbers of every cancer added up together. This is a major global crisis. 5 million hospitalizations, 1 million deaths. Each individual, in fact, has a 50% lifetime risk of a traumatic brain injury. So this is extremely common, and yet we don't really have any good treatments for preventing a traumatic brain injury to result in cognitive impairment. We don't have any treatments. We really, at the moment, if you go into the hospital for TBI, they are trying to keep you alive. They're trying to do that short-term rescue operation. But then after that, whether or not you develop cognitive impairment or not is basically left to luck. Now, neuroinflammation, in principle, should be an easy problem. As an immunologist, we're used to dealing with inflammation all the time. It is a relatively easy and common problem. Anyone who's twisted an ankle or twisted a knee will know what inflammation is. It is the redness, the heat, the swelling. And you'll see that you'll have some swelling after the injury. It goes up, it's painful, and then a few days later, it goes down. There are many different treatments for inflammation, and it is a problem that is relatively easy to deal with. Now, when you get to the brain, this easy problem becomes hard because of the location. And there are two reasons why the location makes inflammation in the brain difficult. One is the blood-brain barrier. This separates the brain from the blood, and it stops many different molecules from crossing over. So you can't just use your normal anti-inflammatories to combat inflammation in the brain. The second big problem is the skull. Now, you'd think the skull wouldn't be a problem for injuries because it protects the brain, but if you do get any damage going through the skull into the brain, the skull now becomes part of the problem. And this is because when the brain starts to swell, like the ankle, like the knee, that swelling is pushing up against a fixed surface. It's pushing up against the surface of the skull. And essentially what will happen after a traumatic brain injury is the swelling of the brain compresses the neurons against the surface of the skull, and those neurons are basically squeezed to death. And that slow inflammatory process leads to a slow accumulation of cognitive decline. This cognitive decline can continue to increase in extent for up to a year after a traumatic brain injury. So how can we combat inflammation? Well, one of the most powerful tools to combat inflammation are regulatory T cells, or Tregs. These are, in fact, the most potent known immunosuppressive. And the reason why they're so potent is because they actually have multiple different molecular mechanisms that allow them to downregulate inflammation. And not only do they have multiple mechanisms, but they're able to sense what is the inflammatory context and initiate the appropriate mechanism in order to prevent inflammation. So they are really a smart system for knowing exactly what needs to be done in order to reverse the inflammation, and they can also drive tissue repair. Now, a problem is that regulatory T cells in the brain are very low in number. In fact, until relatively recently, when we were able to really conclusively demonstrate the presence of regulatory T cells in the mouse and human brain, it was thought that they essentially were excluded. We now know this is not the case, but they are present in a very low number. So then this leads us to two questions. What is it that limits the number of Tregs in the brain? And can we design a therapeutic that allows us to harness the potential of brain Tregs to treat neuroinflammation in cases such as traumatic brain injury? So we start to look at what controls the numbers of regulatory T cells in the brain using a parabiosis approach. What we do here is we take two labeled mice and we join up the circulatory systems in a surgical approach. So now those two mice have a single circulatory system, and the blood rapidly normalizes between the two mice. So now we can say where the cells in the blood are coming from. Are they coming from host 1 or host 2? And we can look at the replacement dynamics in different tissues across the body. So we can zoom in on one tissue. We can look at this set of cells coming past either host 1 or host 2. We can look at the entry rate of cells, of naive cells, activated cells. And we can see that there are regulatory T cells that are coming in quite frequently, especially the activated regulatory T cells. But the problem is that 95% of them are dying or leaving straight away. It's a relatively small fraction that manage to survive in the tissue long term, about 5% of these cells. And these cells have to adapt to living in the tissue environment. Now, the ones that do adapt to living in the tissue environment, they can survive in the tissue for a number of weeks, an average of 2 weeks. And then after that, they're going to dedifferentiate and leave the tissue. So we can take this data where we have measured the replacement value of Tregs in different tissues at different time points, and we can try to model what it is that is limiting the number of regulatory T cells in each organ. And for this, we use a Markov chain Monte Carlo simulation. For anyone who's interested, this is the same algorithm that is basically used to predict what you're trying to type when you're doing when you're texting. It's what controls the predictive text. And it can allow you to predict where cells are moving based on the data set that we have available. Now we can take all this data and then we're able to say, what is the migration control in each of these organs, the brain and other organs. And it turns out that the blood-brain barrier does exclude naive Tregs. Naive Tregs are quite good at getting into most tissues, but they really struggle to get into the brain. But as soon as we look at activated Tregs, which we can see here on the graph, the rate of entry of the ability of Tregs to enter the brain is actually quite high compared to other tissues. It's 10-fold higher than most of the other tissues, and it becomes quite similar to the rate of entry into the spleen or lymph nodes. So this is not the limiting factor. It's not actually the entry rate by which the Tregs get into the brain. Instead, a key limitation appears to be the death rate of the Tregs after they get into the tissue. So Tregs that are present in lymphoid tissues have quite good survival, especially in a tissue like the spleen. But when those cells are going into a tissue environment, that tissue environment is not optimized for their survival, and their death rate goes way up. And in particular, you can see that the Tregs that go into the brain have a rate of death that is about 10 to 100-fold higher than the other tissues. Now, this tells us that the key intervention points to build up those numbers of regulatory T cells in the brain might be preventing this local death of the cells that get into the brain. Now, fortunately, we know quite a lot about what controls the death of regulatory T cells. This is some work by my first PhD student, Wim Pearson, going back close to 10 years now, where we found that the regulatory T cells are almost pre-programmed to die. They have a very high death rate, and what they need to overcome that default death is the provision of a cytokine called interleukin-2 or IL-2. This cytokine upregulates an anti-apoptotic molecule called MCL1, and that blocks the cells from dying. So essentially, these cells are pre-programmed to die, and you really need to constantly feed them IL-2 in order to keep them alive. Now, if we look at the levels of IL-2 in different tissues, you can see that IL-2 is relatively high in the serum at about 3 picograms per mil. It's a bit lower in organs, if we look at liver, intestines, and then it is extremely low in the brain. It is actually produced in the brain by a small number of neurons at very low levels. But essentially, the brain looks like an organ that is almost deficient in interleukin-2. So our hypothesis was that the Tregs are dying in the brain because of this IL-2 starvation. Now, IL-2 is a very interesting therapeutic target. We have the potential to increase the number of regulatory T cells in the system by simply injecting IL-2 into the system. And IL-2 has actually been used as a therapeutic more or less since I was a child. And yet it hasn't really taken off because there are some challenges associated with just injecting IL-2. IL-2 is a very short-lived protein on the order of about 15 minutes. So if you want to have a biological effect, you really need to have a bolus or an infusion at a high dose. Now, the problem with high dose IL-2 is you start to get these off-target effects. There's a high affinity receptor which feeds Tregs, but there's also an intermediate affinity receptor on other cells like CD8 T cells and NK cells. So if you really push the dose high enough, you start to get these off-target effects, which give you sometimes quite unusual immunological manifestations, which we do not want. Now, the other problem, of course, is that if we're going to just inject IL-2 into a patient, into the bloodstream, we're going to have relatively minor effects on the brain, but major on-target effects in the periphery, because we'll be expanding up all of those Tregs in the periphery and causing a peripheral immunosuppression, which is really heavily contraindicated in patients with traumatic brain injury who already have some immunosuppression because of the injury. So essentially, IL-2 is a great idea, but you can't just inject it into a patient because of the off-target effects and the peripheral on-target effects. It would be an ideal therapy, but only if we can come up with a way to get it to be slowly released in the brain without being expressed across the rest of the body. Now, ideally, what we would like is a system where we can inject a patient and then have IL-2 produced in the brain. So the design that we took is to be able to inject the patient with a gene delivery system. That gene delivery would be able to go from the peripheral blood into the brain by itself. And inside the brain, it would transduce cells that can produce IL-2, and ideally would also link that to a small molecule switch so that we can then just induce IL-2 production in the brain whenever we want. That is our model of what we're aiming for. So the way we've done this is to produce a modified AAV. This is an adeno-associated viral vector, which can be used for delivery of different biologics. And what we've done is we've modified it so that we have a neurotrophic capsid, which means we can give a single intravenous injection of the AAV, and it's going to go into the brain by itself without us having to directly deliver into the brain. We then have a promoter that gives it brain specificity so that our biologic is only going to be made in the brain, in our target cells. And then our cargo in this case is interleukin-2 so that we can increase the levels of IL-2 that are present in the brain. And you can see that if we look at the graph on the right, after injection, we are able to increase the levels of IL-2 quite notably by day 5. By day 14, we're really producing levels of IL-2 that are quite similar to the serum, and then it will start to decline after several months. So what does this do to the regulatory T cells in the brain? Well, you can look at the graph on the right now, and this is now plotting the number of regulatory T cells as a fraction of the total T cell compartment. And you can see this is substantially increased even at a low dose of AAV. And of course, as we increase the dose of AAV, we can expand the number of regulatory T cells higher and higher because we're able to produce more and more IL-2. But I'm going to concentrate on the low dose, which creates a level of IL-2 in the brain that is very similar to the level of IL-2 in the serum. Now, important point here is that we do not see any off-target effects. The level is not high. It is similar to the serum, so we're not getting activation of the low affinity or intermediate affinity receptor, and it's restricted to the brain, so we don't get any changes in the peripheral immune system. The other thing about our system is that the promoter that we use does not just give us brain specificity. It is also a promoter that allows some smart targeting to the site of inflammation. So the promoter is the GFAP promoter. This is expressed by astrocytes, which are specialized secretory cells. Now, astrocytes, during an inflammatory event, the astrocytes close to the inflammation proliferate in astrogliosis, so there are more astrocytes, and those astrocytes also upregulate the activity of the GFAP promoter. So here we see a mouse that has been treated with our AAV delivery, and you see the healthy hemisphere, there are a few green cells. These are cells that are producing our cargo. In the same mouse, the other hemisphere has a traumatic brain injury, and you can see that you have much greater numbers of cells producing our cargo, and also a much greater level of cargo being produced per cell. So even though the AAV was delivered across the entire brain, it is specifically being expressed at a higher level in the local region around inflammation, exactly where you want it. So how does this work in a traumatic brain injury model? What we did next is to use the controlled cortical impact model. This is the gold standard preclinical model for traumatic brain injury. Essentially, what you do is you remove the skull so that you can hit the brain at a defined site with a defined pressure for a defined amount of time at a defined depth. So you have a very reproducible bruise that is created on the surface of the brain. You then put the skull back on, and over the course of the next couple of weeks, that bruise results in swelling, pushes against the surface of the skull, and it recapitulates that brain damage that you have happen in a patient who's had a traumatic brain injury. So we can see here a mouse that has got a control vector. They've had a traumatic brain injury on the hemisphere on the right. You can see that there's now a hole in the surface of the brain, and that happened because of that swelling at the injury site, pushed up against the skull, and even after the inflammation has gone away, you're now left with that region of neuron death that is basically irreversible. However, if we give our treatment, here it's a single dose given IV before the injury, you can see that you still have the scarring on the surface of the brain where we created the bruise, but what we don't have is that massive hole where we basically squeeze the neurons to death. So it's visually obvious from surface tomography. We can also look at the effect by histology. And here we can look at on the left, we're looking at a healthy brain. This is how the cortex should look in a mouse brain, a nice, thick, healthy cortex. And on the right, we've got a mouse that has been given a traumatic brain injury. And you can see this cortex at the injury site is essentially gone. And it's gone because of the swelling, pushed it up against the skull, and that cortex is basically squeezed to death. If we look down, we now have a mouse that's been treated with our approach of an AAV-IL2. And you can see that while there is certainly scarring on the surface, you still have a layer of cortex left. You still have neurons that survived the traumatic brain injury. And the lesion size overall is reduced by about 50%. We can also measure this by MRI for longitudinal disease scoring. The other really critical thing is that in traumatic brain injury, we don't just have to rely on measuring neuronal death. We can directly measure cognitive ability. Here we use a cognitive test called the Morris-Water maze. This tests for the ability to create spatial memories. So you put in a maze with opaque water. The mouse wants to get out of the water, so it tries to swim around to find a platform. The platform is in the same place every day, and each day the mouse tends to be able to find the platform a little bit faster because it's remembering from spatial clues in the cage, in the maze, where that platform is. And what you see is that a healthy mouse is able to find the platform much faster. You can look over the summary statistics just for day 5. A mouse that's been given a traumatic brain injury, they don't really improve much at all. They really have a problem creating new spatial memories. Whereas a mouse that has a traumatic brain injury, but has also been treated with our IL-2 treatment, this mouse now has essentially complete correction of their cognitive capacities to make new spatial memories. So not only are we repairing the damage or preventing the damage, we are also preventing that cognitive decline, which is really the key that we want to prevent in patients. We want to see how universal this is. Regulatory T cells have many different mechanisms, so they're able to stop different types of inflammation. So we thought it might have efficacy beyond traumatic brain injury. So here we next looked at experimental autoimmune encephalomyelitis, which is a preclinical model of multiple sclerosis. What happens in multiple sclerosis model is that you're inducing autoimmunity against oligodendrocytes in the brain, and you get this ascending paralysis, where the mice start getting a limp tail at score 1, they get a fully paralyzed tail at score 2, at score 3, they're getting hind limb paralysis. And you can see that the mice that have got disease induced normally, they get the fully paralyzed tail, whereas the mice that have been treated, they get a bit of a limp tail and then more or less get better. We next moved on to a model of stroke, actually 2 models. But the first model is the photothrombotic lesion model. And here, again, we've given the mice a single dose of our treatment, IV, and then we induce a stroke with the photothrombotic laser. Just if you're looking at the size visually, you can see that the strokes are smaller, and if you measure by MRI, you have a 50% reduction in the size of the infarction after treatment. We can move to another model, the distal middle cerebral artery occlusion model, where essentially you are surgically creating a stroke. This is a control mouse. You can see the area that is affected. The treated mouse has got a much smaller area affected, and you can measure this again by MRI. You see about a 50% reduction in this system as well with our treatment. Now, of course, if we're going to go to the clinic, there are a couple of extra features that we'd like to have. First of all, you want to be able to treat someone after diagnosis rather than pre-treating. And then secondly, it's good to have extra ability to control the dose ideally with a dose-dependent on-off switch in the form of a small molecule. So what we did is we modified our approach. We still have a neurotrophic capsid, and we have the promoter that drives this brain specificity, but now we also have a inducible system that is only active when a small molecule is present. And it's that inducer which then drives the IL-2. So this is the construct. This is essentially how it works. You have got the production of this inducible system in astrocytes in the brain. This is a protein that is cleaved in half to create a suppressor protein and an activator protein. And in the baseline state, the suppressor makes sure that no IL-2 is produced. However, if you add the small molecule inducer, which is minocycline in this case, minocycline is quite a nice small molecule inducer because it crosses the blood-brain barrier. It's approved for use in patients with traumatic brain injury, and it's got some mild neuroprotective properties in its own right. Now, minocycline then activates the activator so that now it can drive the production of IL-2. So we're getting astrocyte-specific production of IL-2, but in a manner that is only dependent, that is fully dependent on the small molecule being added. This is how the data looks in practice. We're looking at the regulatory T cells compartment of the brain and the spleen. In the periphery, we have a control vector. We have our inducible vector without minocycline, and we have the inducible vector with minocycline. And we just don't get any effect in the periphery organ, such as the spleen. In the brain, again, we've got the control vector, the inducible vector without minocycline, the inducible vector with minocycline. So you see that we can increase Treg numbers in the brain by adding minocycline. And if we withdraw minocycline, we can see that the numbers of regulatory T cells in the brain drop down to normal quite rapidly. So this is a system that is more or less on and off, and we can also titrate the amount of regulatory T cells by changing the dose of minocycline that we give to the mice. So we can now go back to a traumatic brain injury model, but here we're taking a much more clinical setting. We are first of all giving a traumatic brain injury. So we're treating post-impact. We treat post-impact with an intravenous dose of our inducible vector. We then give oral minocycline. And 2 weeks later, we look at the amount of damage caused in the brain. And we can see here that just as with the non-inducible system, the post-impact inducible system is able to reduce the lesion size by about 50%. So this is really quite promising for taking forward into a clinical setting. So to summarize, we're able to use this system to expand up regulatory T cells in the brain. The system doesn't have any impact on non-Tregs in the brain. We don't have any impact on peripheral Tregs outside of the brain or any other immune cell types outside of the brain. A single intravenous injection gives us quite long-lasting protection. We can see raised levels of IL-2 for up to 3 months. And this system gives us a 50% reduction in the pathology of traumatic brain injury, stroke, and multiple sclerosis models. If we're talking about translation, this inducible system really can create a model where we could potentially give a single dose of the vector intravenously to the patients, and then just give them oral minocycline to upregulate brain Tregs during an inflammatory event, and then we withdraw minocycline when the patient is better. And hopefully we'll be able to go through into the clinic with that system. As I finish off, I really want to thank a fantastic team that has worked with me on this for years and years. In particular, our collaborator in Leuven, Matthew Holt, who's an expert on astrocytes and AAV systems. Lydia Yishi, Pascal Bierfeld, Emanuela Pasciuto, and James Dooley in our lab, who have done a lot of the key work that I spoke about today, and multiple other members of the lab and key collaborators that have really helped us along the way. Thank you.